welcome everybody to our March session of our Illumination series, where we are highlighting people in our community that are doing good systems work, using systems approaches, creating, innovating, and taking chances to do things a little bit differently. So I'm really pleased to welcome Denise Wiseman, Dawn Ellison, and Paul Burens, who will be speaking us today about their Healthcare Reinvention Collaborative based out of the US. And we just really wanted to highlight a group that was using networks, network strategies, network building to facilitate system change. And we just thought this would be a great group to highlight. So welcome to everyone that's here today. And I'll hand it over to our speakers and let them share with us what they're working on.
Wonderful. Thank you, Kyla. So I think we'll just do a real quick introduction of ourselves and then jump in. We really want to be spending time with you more than anything else. So I'm Denise Wiseman, and I call myself the Chief Ruckus Maker here at Healthcare Reinvention Collaborative. And if you don't know the background to the word ruckus making or the thought there, Seth Godin says that after any time that he has a session with a course that he's teaching, and he is all about with positive intent and energy, taking a risk, and as he says, go make a ruckus. And so that's what we're doing with Healthcare Reinvention Collaborative. Dawn, do you want to introduce yourself real quick?
Sure, I'm Dawn Ellison. My passion has always been around collaboration, and I've focused my work in organizations on voice equity in decision making and have found processes that work for that. And as an emergency physician, I've often operated as a fail-safe for a broken healthcare system. And so when I learned about what Denise, Paul, and Lonnie were trying to get started, I was really excited to see what using some of the tools that I'd become familiar with could do in this venture we call Healthcare Reinvention Collaborative. So I introduced them to two loops and a consent-based decision-making process, and they were all in. And so that's how I got involved. Paul?
Yeah, hi. Thanks very much for having us. I'm Paul Burens, a 39-year veteran family physician, and I think I came in here the hard way. Through my career, I practiced good family medicine in suburban Seattle and got several leadership positions and kept trying to make healthcare better. And pretty much everything that I tried failed over and over and over. And in 2020, I retired after going through the torture of another electronic medical record system conversion and didn't want to go back and practice again. Spent a couple of years trying to figure out retirement and then ran into Medicine Forward. Hi, Gabe, who's a founder, and then met Denise. And Denise invited me into HRC, and I had no idea that I would be the fourth member. But I actually have worked with several startups, and I love startups because you actually have some chance to give it some direction. And so for the last year, we've been trying to reinvent healthcare, kind of a Jim Collins-like big, hairy, audacious goal. And using our two loops model and impact networks, we are charging ahead to build a network of networks to change healthcare. And I'm all over it.
Excellent. So I'm going to share my screen. I have a few slides to share. And let me just make sure I grab the right screen here. Yeah, that's right. Okay. So thank you all for being here today as we dive into HRC, the Healthcare Reinvention Collaborative. And before we explore exactly what it is that we're building, I wanted to start with a question that I hear all the time. How are you going to reinvent healthcare? And so just to start right off the top, my response is HRC isn't going to reinvent healthcare. What we're doing is identifying, connecting, supporting, and illuminating the change makers, who I lovingly call ruckus makers, who will reinvent healthcare. But let's start at the beginning. So Dawn, Paul, and I, there's been almost a 2-year trajectory to how we've gotten to where we are today. And I think sometimes history is really important for telling where we're going. And so with this first slide here, I'll just start with the story. So I've worked in healthcare for almost 30 years now. I've had a number of different roles, but throughout my career, regardless of what role I've had, I've seen one thing happen over and over again. And Paul just alluded to that. We try to improve healthcare, but we keep running into the same barriers. We make progress and then we slide backwards. And again, we do that. And I've come to call it performance EKG. The progress, we do some improvement work, it spikes up, and then we turn our back on that and go to something else, and it drops back down. And we're constantly responding to the next crisis. And no matter how hard we work, we find ourselves right back to where we started. And I saw this firsthand when I worked specifically as a patient experience director. We would push to improve experience scores, celebrate a win, and then 6 months later come back to the department or clinic and find that the numbers had dropped. Meanwhile, other departments, quality, safety, operations, whatever it may be, were doing the same things. We're working in silos. We're each trying to solve our own piece of the puzzle. We're looking at our KPIs and focusing on improvement efforts for those, and we're not recognizing how interconnected everything is. So it ends up being like a game of whack-a-mole. We push one problem down and another one pops up somewhere else. The primary reason is we're not addressing root causes or seeing the whole system. Across healthcare, those who are striving to improve the system, whether they're individuals or organizations, they're often feeling isolated in the work that they're doing. Again, they're in that silo. They feel the exhaustion of the uphill struggle, and ultimately they're feeling burnout. And this was before COVID. And then COVID just made everything worse. At the time of COVID, I was the system director of patient experience within a large healthcare system. But after that first wave of COVID, my team of 12 was cut to a team of 3, and I was not one of those 3. So I had a decision to make. I could go back into the system and keep fighting those same battles that I had seen for decades, or I could choose to do something different. And I chose the second path. But what I quickly realized is that my network was small. I knew other patient experience professionals. I knew people working in hospital systems, but I needed to expand and connect with nurses and physicians, pharmacists, administrators, patients, caregivers, even people outside of healthcare who were trying to solve the problem. And so that's what I did. And what became clear was I was not alone. There were many people who saw the same problems and were already working to find solutions, but they were disconnected from each other. They're each trying to reinvent a solution to a similar problem, or again, they're not recognizing the root cause that's resulting in the symptoms they're trying to solve. And so what I saw was purpose-driven changemakers who also felt isolated, like they were pushing a heavy burden uphill alone, and they were getting burnt out. And that's where I questioned, what if we weren't all working alone? And so July of 2023, I invited 20 people from my expanding network, and 9 of those people showed up. And as we gathered to discuss the potential and we shared our experiences, patterns were emerging. What I identified was each of us were looking at the same problems, but through a different lens. The pharmacist with us saw it from his standpoint of pharmacy. The physicians saw it through their clinical experience, which differed from the experience or the perception of the nurses. And then patients, of course, were seeing it through their lived experience. And yet underneath it all, most of the root causes were the same. And we weren't fixing the system, we were treating the symptoms. And that's when I proposed that we don't necessarily need more solutions, we need connection. We need to figure out how to bring people together, not just to share ideas, but to truly see each other, to recognize the shared challenges and to collaborate in ways that actually will make lasting impact instead of repeating the cycle over and over again. And so that was the very beginning of HRC. Along the way, oops, that's right. Go here. So at first I thought that we would be building a hub. It would be a central place that could help people find others, but that central place would do the work of that. But then one of the people in that first group, and he's actually on the call today, it's thrilling to see, Gabe Charbonneau, introduced me to the concept of network weaving. There identified creating a hub is a phase of network weaving, but you can't stop there. You can't be dependent on a central organization or structure to keep everyone connected. Real transformation happens when networks connect to other networks. And when we move from isolated efforts to woven collaborative systems where people aren't just meeting us, HRC, but they're meeting each other. And that sparks innovation and amplifies their impact and creates sustained change. And that's what we're seeking to do. So we're learning from individuals such as David Ehrlichman, who wrote Impact Networks, and we're modeled after the theory of change 2 loops model, which Dawn and Paul will talk about both of these. And through this work, the 3 of us have come together. So Dawn introduced us to 2 loops, and in my exploration to learn more, that's actually how I found SI Network. So talk about connecting the dots. And so we, the 3 of us, along with a couple others, are working to create HRC. What does this actually look like in practice? Well, we're building a digital community. We're using the same platform that SI Network is using. As a matter of fact, we've been on Mighty Networks for quite a while now. We're creating an online space where people can connect and organizations can find each other. We can share knowledge, we can collaborate, but a digital platform is not going to do it. It is kind of cold. It's not really engaging. It's not real-time collaboration. So we're also creating an impact network map, a visual representation of connections across the ecosystem. It's not just a directory, though. It's a visual tool and it's interactive. So it lets us see relationships, to identify gaps, and to find opportunities for collaboration that might not be otherwise visible or seen. And so the work of HRC is to really pay attention to that map and help make introductions and identify gaps. However, it is a tool that our members have access to and can engage with. So it's not just a we feed it to somebody, it's everybody's engaging in it. And then the other thing we're really leaning in on, and Dawn will talk about this, is our events and gatherings. Digital spaces are great, but they're not enough. We're creating those structured opportunities for people to connect virtually, hopefully someday in real life, but to make new connections, to deepen relationships, and to ultimately take action together. And this isn't just about one organization, HRC, trying to drive change. It's about building a movement where everybody can contribute and see their role in the bigger picture. And so this is just the beginning. HRC isn't an initiative. It's not a program. It's not just a network. It is a movement of change makers, visionaries, doers who believe that we can transform healthcare, not just by fixing the broken parts, but by truly reimagining the whole system together. And so as I end my little spiel here, I'll end it with a question. What would be possible if we truly worked together? Because that's what Dawn, Paul, and I are exploring and trying to figure out. And this is, as I'm sure Paul will say as he speaks with you, this is emergent. We don't exactly know what this is going to end up being. We are feeling our way and learning and inviting the community alongside with us. So Dawn and Paul, I'm done. One of you's next.
Dawn, you want to go first or you want me to?
I can, sure. So, what I was going to do is talk to you a little bit about two loops, and I know that many of you are already familiar with that, so I won't spend a whole lot of time on it. But I'm just going to bring up, as long as Denise's slides are gone, I'll bring up my own little picture of two loops. So Two Loops model of change comes out of the Berkana Institute, and it describes an organic process where an old system has a life course, and at some point, that old system, let's call it healthcare, no longer serves people well, and people see a better way of doing things, and those people are the innovators, the ruckus makers, the pioneers. And as they step out of the system to create something new and different, like Denise talked about, they can feel pretty isolated. And what Berkana Institute talked about was, well, what if we were to name those innovators, connect them, nourish their communities of practice, and then illuminate the work that they're doing? The idea behind that is to accelerate that emerging new system that hopefully is better and has learned from the old system. Just briefly, the two loops theory. So let me stop sharing that. And then the other piece that I brought in was something that really resonated with the people that were involved in HRC at the time, and that was this idea of horizontal governance. Samantha Slade took a consent-based decision-making process and combined it with art of hosting techniques and wrote a book called Going Horizontal. And the process that she describes is called generative decision making. It can be done quickly, and it assures voices are heard, what I call voice equity. And it asks the question, is this solution good enough for now and safe enough to try? And that is something that at HRC we've found to be very helpful in governing the decisions, making the decisions to move us forward into getting traction on the work that we're so passionate about doing. Paul, I think I'll turn it over to you for impact networks, and maybe I'll jump back and talk about events after that.
Okay, well, as is usual, we sort of program what we're going to do, and then we don't follow our program exactly. I have to add on to the two loops model. I know you're all familiar with it, but when I heard about it, which was just a year and change ago, it immediately became obvious to me that it was biological. That, I'm a doctor, and I studied biochemistry in college, and then medicine and physiology and all of that stuff. The two loops model is a biological model on how organisms, that is to say humans, can work together and create something that emerges with new properties. As Denise said I was going to say this. New properties emerge as biology develops. A single cell becomes a multi-cell, becomes organs becomes a whole body. And we're doing the same thing by pulling this together. And there are lots of elements pulling it together. So our playbook is impact networks. And, at first I learned the two loops model and was blown away by that, and then read through impact networks and realized, oh my God, there's a laid out playbook for how to do this. I don't have to create the wheel. So another analogy that hasn't come up yet that I love and I keep using. In the US, women didn't have the right to vote in 1840. But 6 women got together at Seneca Falls and sat down and had tea and decided that they ought to have the right to vote. So they started with 6. And 80 years later, they were all dead, but women got the right to vote in the US. It was a movement. And it took 80 years because they were living in the horse and buggy telegraph days. Right now, we're in international Zoom water with AI tools to summarize our meetings. And we're trying to develop what a network of networks using that playbook that David wrote. And his mantra in his book is networks grow at the speed of trust. So we're very deliberate about having meetings and decisions in which people trust each other. Every voice counts, everybody is heard. And most interesting thing to me about this build out is that not one of us inside HRC has ever seen anything like what we're building. We've always lived in hierarchical structures, top-down organizations, and spent careers in those kinds of organizations. And we're building a horizontal, non-hierarchical network of networks like we've never seen before. It's really creative, and it's a whole lot of fun. And you get to meet people and keep meeting people and keep meeting people and keep meeting people. And it gets bigger and bigger. And it's a small startup at the moment, but we went from 0 to 250 members inside of a year. And the goal is to grow 10% a month. And I have a goal in my head. It's just mine, but I want to see us with 100,000 members. And yeah, we're not even close. But if you don't have a big, hairy, audacious goal, Jim Collins will tell you in the book Good to Great, you're not going to accomplish very much. And to build that big, hairy, audacious goal, you need what he calls a flywheel. Well, what we're building inside of HRC is indeed something like that. It's the network map that allows people to connect. And how do you connect? Well, he uses the analogy narrow bridges and wide bridges. So for example, we reach out to another organization, we have one contact person. If you let it stay there at one contact person, when that person has an adverse event in life, decides to move on, leaves, gone, they're not there anymore, your entire connection just disappeared. That's a narrow bridge. We want bridges that are wide, that are redundant. So one person drops out, someone else picks up the pieces. The connection is organic and institutionalized. It doesn't go away with an individual. So HRC won't go away if I die tomorrow. Somebody's going to replace me, and we're going to keep moving it forward. That's how those women got the right to vote, is even though they were dying along the way, they created a movement of more and more and more people until it was a national movement, and it worked. Now, reinventing healthcare is a ridiculous goal. It's a sixth of the US economy, but it can be reinvented if everybody who wants to reinvent it gets together and figures out a way, or multiple ways to make it happen. And there are ideas out there, and there's innovators, and we keep meeting them. So we have a task we just decided on literally yesterday. We've made a list of a bunch of organizations and individuals that we think we should probably let them know about us. And so we're going to go after that list, at a few a week, each of us, until we get through all 675 organizations and people. Yep. Just work down the list. And it's like working down a backlog of undocumented office visits, right, Dawn? Using that EMR. It's ugliness, but we get through that, and we don't know in advance who's going to be our friend and who's going to ignore us, who's going to jump in with both feet. And so, well, we've really made a decision for ourselves to go and chew down through the list. Because what? Because we're trying to build a network of networks of innovators in a flat, non-hierarchical structure. We're not deciding in advance who's going to join us. We're opening the door. That's not the same thing. There's nothing hierarchical about this. When you join HRC, you're in. You think your voice doesn't count? You're wrong. You're already in. You don't even have to do anything. But there's more if you join us. And yes, there's a need for some small amount of money to keep the doors open. So we have a membership, but I'm starting to ramble, so that means I'm done. We should open up plenty of time for questions and answers, right?
I think Dawn was going to give us a little bit on events.
Yeah, tee it up.
Sure. So We are starting with a few monthly events. One of them sounds very familiar to what you're doing today. We call it Shine a Light. And what we do is we offer 3 to 4 of our members to get in front of our participants, our network, and tell about the work that they're doing. And after they've described the work that they're doing, then we ask them to ask for what they need and offer what they can. And we find that that is one of the agreements in our network that seems to work well and builds bridges. So that Shine a Light event, actually, our second one is happening today, later. That really helps our network members learn about each other. And yeah, we're starting to build those bridges in doing that. And then another of our events is we just call it a public monthly event. And those are themed. And we've come up with some themes that we feel like tell a story, right? One of the things we learned out of impact networks is it's important when you're building a network to find out how we got here. So with healthcare, how did we get into the situation that we're in with healthcare right now? So in April, we're bringing together 3 panelists who will help us understand that in order to figure out what the levers are, what we can change to make a difference. We might want to know how we got here. So those public themes tell a story throughout the year. March 25th, we're talking all about compassion, which, as you can imagine, is a really important theme in healthcare. And then, of course, we have our mapping events, which Denise touched on briefly. That is where we get to play with the map and see how it's developing. We always give people time to go into their profile, make sure that it's up to date, and then they get to see how their connections have changed over time. So that's our mapping event. And then, of course, we have quarterly check-ins and updates, which is an opportunity for people who are interested in HRC to learn about what we've done in the past quarter, what we have in mind to do going forward, and really to hear from them about what their needs are and what we as a core group might be able to offer them. So right now, those are our kind of basic events that we're doing. And of course, all of those are in an attempt to make those connections, build those deeper relationships. Almost all of our events are followed by 30 minutes of what we call network conversations, where we throw people into pairs or triplets, and they just get to chat for a little while. And we do about 3 rotations of those, and people just love those. So we are really trying to do what we say we're meant to do with that. So
Gabe,
Denise,
oh,
go
I'll
ahead.
just give Gabe has his hand up, so I'll just give him a
Okay.
chance to
Yeah.
Sorry, I
ask a
didn't have
question.
my screen
Oh,
up.
that's
Hey,
okay.
Gabe.
No problem.
No worries. Yeah, no, I'm delighted to see these 2 groups together. So I've been on the on the SI Mighty Network for a while, and I've read through a lot of your materials. In fact, like when we were creating our organization, Medicine Forward, I was intrigued by a lot of what content you guys had put out and been thinking about as far as like how we might build our organization. And I think you saw my picture on some of the early things with HRC. Like I've been interested in what they're doing for a long time too. So I think this is just like a really cool connection to see. I have a couple things I'd love to share and also a question. The things I want to share, Paul, if you haven't read Donella Meadows' Thinking in Systems, a primer, that's a book that I can tell you're going to love, and I am guessing others on this Zoom may be quite familiar with Donella Meadows or read her stuff as systems thinkers. But I go back to her and her work a lot. and am inspired by it. And in fact, like as HRC was sharing their kind of 3 things they're working on, it's in my mind, I'm thinking about sort of her um, identifying leverage points of where, like, if you want to create change in a system, where are the leverage points and kind of what amount of impact does each one have? And so I'm sort of thinking about your map and events and the other things, and like sort of, are there ways to understand the amount of leverage they have, or ways to increase the amount of leverage they have, or any of us that are these ruckus makers, how can we have more? Yes, thank you, Kyla. That's exactly one of the links I was going to drop in the chat too. There's so many places where my brain is ping-ponging, like dot connecting. Paul, I also love good to great. I'm just going to share that. So before I get to my question, the last share, I just learned about a really cool AI tool called comodel.io, and it's from another systems thinker. And basically, you can put in there a question and then any resources you want to use, and it tries to do kind of automated causal loop analysis. Like it basically will create a systems map of how things appear to be impacting each other and what are the reinforcing and balancing loops. I've been having tons of fun playing with that tool, and I guess I just wanted to share that in case anyone else has fun exploring that. And I think it has relevance to all of this conversation. My question actually for SI is, since I'm sharing things I'm excited about, when you think about reinventing healthcare, are there particular like system thinking tools or approaches that you would recommend for either HRC or our group or anybody who's like kind of stuck in broken healthcare? Because we've heard sort of HRC's approach, but I'd love to hear your take on things that you would like to see people using that they maybe aren't using enough, that might positively disrupt the broken healthcare status quo. So that was a lot. Sorry to, I just am very excited about, like, there's so many things about like what's going on here that excite me. I couldn't help myself.
Well, I can speak for myself and then I can hand it over to Rosina and Anne-Marie for their perspective. But the one thing that I've been really interested in for healthcare system is that the concept of learning health systems or human learning systems, and how do we shift from our hierarchical, measures based, and not that measures are bad, but it's almost like I've seen sort of a gaming of the system where, it's like, how do we ask the question where all of our metrics can be green? And, how do we, just make the results look good because we're too scared to say differently? And so the work of Toby Lowe has been really influential on me. I know Scotland Healthcare Improvement, or the Scottish system is working with Toby Lowe and starting to incorporate this human system learning theory and concepts into their healthcare structure. And so I'm just sort of dipping my toes into that, but I think that has a lot of potential in terms of this, is it good enough to go, and is it safe enough to learn, to try? Like, I think that's really the foundation of this human learning system is, to experiment and to try things and to open up the aperture of all the options that are out there, and to come back in a structured way to say, well, what did we learn? What do we know now that's new? What should we do differently? And it's not just a implementation plan that usually kind of dies a slow death as people kind of drop off the implementation work. So it keeps that work alive. So that's what, for me, that's really what's kind of getting myself interested in a systems approach. I'm not sure if that's really a systems approach, but it's definitely a shift in our system. Anne-Marie and Rosina, do you guys have any thoughts on your promising practice for systems approaches?
Yes, thank you, Kyla. Yes, here in Barcelona, we are leading the Living Lab for Health at IRSI-CAIxa. IRSI-CAIxa is an institute of research located in a hospital, and we also do lots of the things that you are saying here. So we facilitate innovation networks, and we invite them to go through processes that are scientific. So we perform community research, community-based participatory research process with different stakeholders, creating a network, because we believe that the process is so complex, because there is so much complexity that it requires to be done through transdisciplinary research, we call it. So integrating knowledge from different services in the hospital, different academic partners, but patients, families, so knowledge inside and outside academia, in order to better understand the problem and then better design solutions. And that's basically what we do, and we use systems innovation approaches to do that.
Excellent.
And Anne-Marie?
Yeah, and I'm walking outdoors with my dog right now, so I'll just stay camera off so I'm not giving everybody like motion sickness. No, this is very interesting, kind of the work you're embarking on. And so what I'll share, obviously, like we are all doing, is just based on my experience. So I started working in healthcare in 2012. Prior to that, I was working in management consulting. And we were bringing some of these large scale systems approaches based on systems thinking, based on complexity science. And of all the projects we worked on, I've always noticed that the ones that I got more interested in were in healthcare, because the system is inherently more complex than any other sector out there. And so I said, okay, I want to shift in healthcare. I want to bring this in. Healthcare needs it. But I noticed such a big resistance to these approaches in healthcare. While they are embraced in other industries, there's more hesitation in healthcare. And part of it was I'm not clinically trained. So in healthcare, so far my experience has been my point of view, my credibility is so diminished. So I think how do we create ways to make sure to have these conversations, everybody has a perspective. It's not only the clinicians. And I think we're seeing this now with the like patient advocate movement, right? And patient going, wait a minute, like I'm also part of the system and I should have a say. It's not only a clinically driven decision-making system, for example. So I think creating ways to create space for everybody and getting everybody on board with that is important. What I've noticed is with systems thinking, and if you follow, some big thinkers out there, there's a difference between system thinking and complexity science. And sometimes some of the trap we have around systems thinking is, if you could just map the system, we could understand it and we could fix it. But complex problems can't be mapped because complexity inherently means that the system is always evolving, new things are emerging, and so your map is out of date by the time you drew it. So I think we have to be careful of not falling into that trap. But that said, I still find value in bringing people together and using some of these approaches to generate kind of more shared awareness. Because what I've noticed in healthcare is I think we're not necessarily all clear on what is the problem we're trying to solve. We think we are, but we don't spend enough time being clear on that problem. And then how do we work together to achieve kind of an outcome? So when it comes to complexity science, there are different tools for that, which a lot of them are based on creating that collective awareness and then testing out those small actions. And I think I love from this talk that example of, could we try it out now? Is it safe? Like those little things and just learning to experiment. And so lastly, what I'll say is I think in the health system, when you have all these professionals who've been trained to work based on evidence, and I find it interesting when we try to apply new ways of doing, if there's no evidence for something, then there's hesitancy to trying it out. But at the same time, if this current situation, this current context never existed before, there won't be any evidence. So I think learning to fail safe is also important. So anyways, I'll stop. That was long enough, but those are my synthesis of why it makes it hard to bring this into healthcare. But I think the networking and the awareness building that you are generating, that's a big part of what needs to happen. So I support that.
Thank you. I'll tag on to one of the things you said, Anne-Marie. It's not just fail safe, it's also to embrace that we have to fail in order to find our way. So celebrate that we failed, right? So that we can learn from it. We can then go to the next attempt. But our culture, our systems tend to look poorly upon risk and failure. And so that's a challenge that a mindset shift that we have an opportunity for.
Absolutely.
Gatwiri, do you want to ask your question or make a comment?
Yeah, actually, I want to share my experience because this is what we are doing in. I cannot share the institution I'm working with, but we are actually already working on bridging networks on, the fragmentation, the silos in healthcare, because healthcare has been siloed for a long time, because we were focusing so much on triple M because of the performance-based approach. And now we saw so much burnout to a point where the essential workers, mainly the physicians, were burned out. I know some physicians here, especially the primary care physician, they were given 1,200 to 2,000 patients per panel to take care of them. That was impossible. I mean, that's still impossible. How are you going to take care of them? So we did thorough research, and then we realized 20% of medical intervention, 20% is what makes medical intervention, and then 80% is determined by social determinants of health, upstream approach. So what happens is we have to think about system thinking, and that's what is happening, meaning that it's outside the four walls of the hospital. So what happens is we have to think about collaborating with people outside the hospital, meaning that we have to we have to partner with CBOs, local governments. We have to go boots on the ground with, like what Anna said, with the patients and see how they're living, what are they eating, what is their air quality, and so many other upstream factors that are affecting them. And those are the kind of stuff that we have. And we have data that we can collect. We can use different models. Like we have actually different models. I'm gonna plot that in to provide you guys that information. So these are actually ways we can approach that. And what they are using is that collective impact model. So instead of us trying to reinvent new wheels, we can actually start with something because we're already system thinkers. We can start with what is already being done before others jump on it, and then we are already way far behind.
That's excellent.
Fantastic. Yeah.
Kind of a final comment. Neither Paul or Dawn or myself would say that we're the expert on exactly what we're doing, but we recognize the value in it. And part of that network we're seeking to create is networking with SI Network and the experts that are within there. All of these resources that were shared during this time, it's how do we pull all of that in so the collective awareness, and that we can say, we're not the expert, but we know who is, will direct you in the right place. That's how we will support. We're not going to carry the load of all of that. The system, the network that we create will help to carry that so that we can find it and thus be able to provide what is needed to each individual person or group that is working on whatever their action may be and what their resource needs are.
Yeah, and I would say the same thing for us at the SI network, right? Like we're, we've got people from all over the world that are working in many, many different contexts. And our goal is to really help them connect and find the people that are working in their space and the world that they're working in. And then have a bit of a community where we're trying these approaches together and learning from each other from these approaches. So, I'm looking for people who's trying ripple effects mapping, who's doing social network analysis, how is that working for you? What did you learn as you've been doing it? Who's doing system mapping in your system? Is it working? Is it not working? How do you do it? Is it 1 hour? Is it 4-day workshop, like the real nitty-gritties of, because these approaches are quite new in healthcare. And so I think it's important for us to share, if we're trying these things, what we're learning from them as well. So so I think that's where these communities and these networks have a real value for all of us that are interested in using these approaches and these tools. We also need a bit of community of practice for ourselves of how we're using them and what's working and what's resonating in healthcare. Because I often find that some of the tools resonate in other system improvement working spaces, but they don't work for the culture of healthcare that has its very unique hierarchical risk minimization kind of culture. So and control, right? Like a lot of people with a lot of control. So yeah, so I think, you know, these networks are really powerful. Sorry, Paul, go ahead.
Oops, you're on mute, Paul.
Yeah, I have to put in a quick plug for the dismal science, as John Kenneth Galbraith named it, that is economics. It's been my observation over my lifetime that healthcare is driven by money. If you don't follow the money, you can't figure it out. It's very complex, but if you follow the money, you'll find out how it actually works. And if you change how the money flows, you can change how it's structured. So let's not forget economics as we go along. It's really important.
Well, and Paul, to that, of course, and you hear me say this all the time, that balance between predatory capitalism versus conscious. So how are we recognizing the need for money to fuel any work and effort that happens? However, that balance that seems to be tipped in the wrong direction right now, with too many people making way too much and others just without. Pilot, one of the things that you said that also brought to mind for me is so often in healthcare, at least in the States, and I'm assuming it's almost anywhere else, somebody has a solution that works in one time, one place, and all of a sudden they're the Pied Piper and everybody wants what they have and assume that if I do exactly what they did in my environment, I'll get the same outcomes. And that doesn't work. And so how do we have that proliferation of tools and knowledge that people can come and say, what can I look at and try to identify might work here? And again, test, fail, try again, but not spending the time and energy thinking that that solution is going to be exactly what I need.
Yeah, and that's where I really like the work of Mary Bean and her adaptive complex system approach, where you have to take the innovation, you have to take the operational system that you're working in, and then you have to have that adaptive space where the solutions for your own context and your own world and the people that you have and the strengths that you have are all sort of built together that in a unique solution that's fit for your particular situation. So we really lean heavily, I really lean heavily on that model as well. I think Mary Bean has some really great work in that, but it's the space of adaptive process where we don't really know what that looks like or how that works or how to set up workshops that allow for that emergence to happen and that conflict to happen and that adaptation to happen. So that's really, I think, what a lot of system workers are exploring is that interface between innovation and the operational system and how to make that work. And that's really, you know, that there's no clear answers in that. That's all experimentation.
I don't know if this helps, but so two things, the Assyrian mapping training I referenced in the comments, but also this other organizational and relationship systems coaching I took. There was a principle from both that I found quite valuable, which is about like the system inherently has the intelligence and the tool and the knowledge it needs to change. And so sometimes it is best to see what is possible within this system right now to try to nudge it in the right direction rather than trying to push something that the system might not be ready for, doesn't understand the concept. So you could spend and waste a lot of energy trying to bring in something external rather than starting with where is the system now and where would it be ready to start moving that brings us closer to a better state than what it currently is. And as somebody who likes to solve problems, I was like, oh, right. I just need to be a bit more patient sometimes because forcing will actually just create more resistance.
Yeah. And on that, Anne-Marie, we spend so much time and energy hiring excellent people, but then we discount the experience and knowledge that they bring to our organization when we look outside and see a shiny object and assume that they know better, they have the path. I think you're right. The first thing we could and should do is ask, what is it that we have inside? What could we do? And I'm a big fan of liberating structures, and one of my favorites is 15% solutions. So, what is that little bit that we can do? Because the slow and steady change is often the change that sustains and is built upon and grows until you get to that tipping point. But we are not patient. In healthcare, we set a KPI and we want it, we say at the end of the year, but we really want it next month.
So I'm just looking at the time clock. I could talk about this all morning.
know.
This is so fascinating. But I just want to use the questions that you guys use in your workshops to end our session, which is, what do you need? You know, the Healthcare Reinvention Collaborative, what do you need? What are you looking for? And then what can you offer? And maybe we'll just end with that.
We might each have a different statement, so I'll try to be succinct with mine and give Paul and Dawn a little bit of time. So I think what we offer is that space where all voices are welcomed and matter and have that opportunity to contribute what they have, learn from those who are there, but make connections and collaborate and learn together. What we need, you know, we need more of this type of conversation and thought leadership, that contribution, so we can offer, here's what we're doing. Tell us what's working, what's not, what are the barriers, and offer us. I've got, I don't know how many links I've opened up in this conversation that are going to give us more paths to emerging what we're going to become.
Great.
And
Dawn,
I'll go next. So I would say what we need is to get the word out, to spread the word, to build our community, because, you know, that's where the collective intelligence is in the people that we can bring together, that we can connect, and that we can help to learn to collaborate. And as far as what we offer, I'm probably going to say pretty much the same thing that Denise said, is we offer, you know, this space for your voice to be heard, because we really value that voice equity, that all voices matter, that everyone has something to say, and they can influence the direction that we go in. So that's how I would answer those two questions. Thanks for asking that, Kyla.
oh, I love those questions. I'm going to totally put those on a sticky note on my computer and use them all the time. I think it's great. Those questions are great.
Yeah.
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 And Paul?
I think what we need is larger and more connections and wide bridges with those we want to work with, like SI Network. Wide bridges means more than one connection. There's 3 of us here today to connect with you, and there's more than one of you here today. That's what a wide bridge is. What can we offer? Stuff that you can't see coming. Emergent properties. That's what the network of network will build. It's already happened. You know, we've got a couple of blurbs now on our website from a couple of people who joined us for a while and discovered things that they didn't know they needed to discover. That's what we offer. We offer a mechanism by which people will discover things that they need that they didn't even know they needed. That's evolutionary magic, and and it's real. So that's the whole reason I'm doing this. We're going to build something that we haven't seen before.
Amazing. Well, if that doesn't give you some inspiration to put a little hop in your step today, I don't know what will. So really exciting work that you're doing. We're so proud to be connected with you and to know you all and to collaborate as much as we can. We'll continue to keep building our mutual networks and share in our learnings together. And yeah, we are recording this session, so it will be shared and you can share it with other colleagues. I think it's an hour that's worth many people's time to just listen to it. And I'll also save the chat and make sure we've got that accessible to everybody, so those links are alive. So continue to connect, continue to grow your networks, and we'll check back in soon.
Thank you so much for this opportunity.
Thanks,
I'm
Kyla.
grateful.
Thank you. Have a good day, everybody.
Grazie
too.
mille.
Bye-bye.
Bye bye. Thank you.